Good afternoon. I am honored to share our experience with sequential living donor liver transplantation for high-risk hepatocellular carcinoma following liver resection. In Taiwan, the organ transplant outcomes are published regularly by the Ministry of Health and Welfare to ensure public awareness and transparency. Our center continues to be the most active liver transplant center in the country, with the highest survival rates of 91% at 3 years. To date, we have performed over 2,400 liver transplants at Kaohsiung Chang'an Memorial Hospital, 89% being LDLT. The most common indications in adults are hepatitis B and C. Among them, approximately half are HCC cases. According to our hospital's cancer registry data, liver transplantation achieves the best 5-year survival rates regardless of HCC staging, compared to those treated with resection, local regional therapy, radiotherapy, and chemotherapy. Liver transplantation remains the optimal curative treatment for HCC. However, due to organ scarcity and the strict selection criteria for HCC, liver resection is frequently employed as an initial treatment. While potentially curative, liver resection is plagued by high recurrence rates, reported to be over 70%. An approach starting with primary liver resection and potentially followed by salvage liver transplantation in case of recurrence or liver decompensation is considered a viable option. However, concerns about the rates of secondary transplantability have prompted the consideration of sequential liver transplantation. The sequential approach is performing liver transplantation preemptively before recurrence following primary liver resection for selected high-risk HCC cases. These high-risk features predicting recurrence after liver resection include largest tumor size over 5 centimeters, total tumor diameter over 10 centimeters, presence of satellite lesions, vascular or bile duct invasion, and poor tumor differentiation. This proactive approach addresses both potential recurrent HCC and underlying liver disease. Our first sequential LDLT patient underwent liver resection in the year 2001 following TACE for 3 times. His resection pathology showed multiple tumors and with microvascular invasion, for which sequential LDLT was performed 3 months later. Explant showed only 1 small HCC not seen on pre-transplant imaging, and the patient remains recurrence-free for almost 23 years. In addition to preemptive LDLT following liver resection with high-risk pathologic features, we expanded the scope of sequential LDLT by including those performed following liver resection as a downstaging strategy in patients with initial HCC beyond transplant criteria. This is a case of hepatitis B and C co-infection with high viral loads and a large 11-centimeter HCC in the right liver beyond transplant criteria. Right lobectomy would leave an inadequate remnant volume of 27%. He underwent TACE with drug-eluting beads twice. Fortunately, tumor shrinkage was noted with regeneration in the left liver, making right lobectomy feasible. The pathology showed moderate differentiation and 95% necrosis. Antiviral treatment was continued. Sequential LDLT was performed 4.7 months later, when negative HBV and HCV viral loads were achieved. No tumor was found on pathology. He remains recurrence-free 11 years to date. With the availability of more powerful treatment modalities in recent years, we have been able to combine liver resection and local regional therapy to downstage locally advanced and aggressive HCC to sequential LDLT. This is a case of a large 18-centimeter HCC with right lobar portal vein tumor thrombus and multiple bilobar satellite nodules. We performed right lobectomy with tumor thrombectomy. Pathology showed poorly differentiated HCC with macro and microvascular invasion. As for the multiple residual tumors, Y90 radioembolization was performed for further downstaging. After Y90, there was only one viable lesion in segment 4 with FDG uptake on PET scan. TACE was performed with the goal of achieving complete pathologic response. Sequential LDLT was performed 7.4 months after liver resection. Final pathology showed 100% necrosis of the segment 2 tumor and 95% necrosis of the segment 4 tumor. Interestingly, tumor differentiation improved from poor to moderate, showing that Y90 may have also changed tumor biology. She remains well and recurrence-free for over 2 years under prophylactic lenvatinib. 765 HCC patients received LDLT at our center. 27 patients underwent sequential LDLT, of which 22 were preemptive for high-risk histopathology and 5 as downstaging. 5 patients had tumors larger than 5 centimeters. 7 had more than 1 tumor during primary resection, with 2 having total tumor diameter exceeding 10 centimeters. Satellite nodules was present in 4 patients, microvascular invasion in 14, extensive PVTT in 1, and bile duct invasion in 1. Median interval from liver resection to LDLT was 5.6 months. 2 patients experienced HCC recurrence. 1 had late extrahepatic recurrence at 6.9 years post-LT and received radiotherapy. She is maintained on lenvatinib and remains stable 8 years post-LT. The other patient developed early intra and extrahepatic recurrence at 1.4 years post-LT, underwent chemotherapy and proton beam therapy, but eventually succumbed to the disease at 2.5 years. 2 deaths included the one with HCC recurrence and another who died from heart failure at 12 years post-LT. The 1, 3, 5-year overall survival and disease-free survival were 100%, 96%, and 96% respectively. Sequential LDLT represents a promising approach in the management of HCC, offering tailored solutions for patients with locally advanced disease. By integrating preemptive LDLT and downstaging strategies with multidisciplinary treatment modalities, sequential LDLT aims to optimize tumor control and long-term outcomes while minimizing the risk of recurrence. Continued research and collaborative efforts are essential to further elucidate the role of sequential LDLT and refine patient selection criteria in the era of modern transplant oncology. Thank you.